Hi guys, welcome back to my radiology review series. This is part 3, and in this video we are going to focus on some of the most common urological investigations that you might find yourself needing to order. So let's get started. So before we start answering any questions, I would just like to introduce us to the various investigations that we're going to look at. So this is a retrograde study because the contrast is injected in a retrograde direction with respect to how the urine flows. So basically this is what I was talking about. This picture right here is showing a retrograde urethrogram. As you can see, the catheter is right here and the contrast is being injected in a retrograde fashion all the way up into the bladder. And then this is a voiding cystourethrogram, meaning the contrast is injected directly into the bladder. As you can see, the contrast is densest in the bladder before flowing out to the urethra and any other structure. So station 9 says, describe the image. What is your diagnosis? How is your diagnosis graded? So the image shows a voiding cystourethrogram in which contrast in the bladder refluxes into the ureter and extending into the renal pelvis and calyces on the right side. So this is a voiding cystourethrogram like we discussed earlier, and it shows contrast which refluxes into the ureter and extending all the way into the renal pelvis and calyces on the right side. That is what I was describing here. And then number 2, what is your diagnosis? So of course this is right-sided grade 3 vesicoureteric reflux. I'm going to explain why I'm saying this is grade 3 very shortly. So number 3, how is your diagnosis graded? So this pathology can be graded from grade 1 through 5. Grade 1 being just reflux confined to the ureter. Grade 2 having reflux into the renal pelvis with no dilatation. Grade 3, reflux into the renal pelvis and calyces, mild ureteral dilatation and no hydronephrosis. Grade 4, significant reflux, dilated ureters and renal pelvis, and mild hydronephrosis. Grade 5, severe reflux, massive dilatation of ureters and renal pelvis, severe hydronephrosis and possible renal damage. So we are saying our diagnosis is grade 3 because reflux into the renal pelvis and calyces, mild ureteral dilatation and no hydronephrosis is exactly what is seen here. So the reflux extends all the way up into the renal pelvis and calyces, and there is only mild ureteral dilatation, as you can see here. So just to give you an idea, this is what grade 4 would look like, and grade 4 was described as significant reflux, dilated ureters and renal pelvis, and mild hydronephrosis. So I'm sure you can see the mild hydronephrosis here and here, as well as the dilated ureters here. But in our diagnosis, the renal pelvis and the ureter maintain their normal shape. And then this is what grade 5 would look like. Severe reflux, massive dilatation of the ureters and renal pelvis, severe hydronephrosis, and possible renal damage. So our diagnosis is right-sided, grade 3, vesicoureteric reflux. Station 10, describe the image. What is your diagnosis? What are the indications for this investigation? So the image shows a retrograde urethrogram which reviews a narrowing of the bulbar urethral lumen with tapered margins. So just a recap of the urethral anatomy. This is the prostatic urethra in between the prostate. This is the membranous urethra, and the bulbar urethra is right here, and the penile urethra is right here, which is why we described our findings as a retrograde urethrogram which reviews a narrowing of the bulbar urethral lumen. So this is the bulbar urethra right here with tapered margins. So tapered in this case simply means this progressive narrowing, as you can see here. And then there isn't any significant urethral dilatation proximal to the narrowed site of the urethra. proximal to this, which is this direction. And then there is no obstruction to contrast flow at the narrowed side of the urethra. So as you can see, the contrast is able to make its way all the way up into the bladder, despite this characteristic narrowing right here. So the diagnosis is a bulbar urethral stricture. Number 3, what are the indications for this investigation? So the indications for a retrograde urethrogram include suspected urethral strictures, urethral trauma, or congenital anomalies to do with the urethra. So under urethral strictures, these are some of the things that might cause urethral strictures. They cause recurrent inflammation, which might lead to fibrosis, and the fibrosis may lead to urethral strictures. And then these right here are just the signs of having a urethral stricture. So whenever you have a weak stream, dribbling, or hesitancy, that might be indicative of a urethral stricture. And then urethral trauma. So pelvic fractures might cause urethral trauma, as well as iatrogenic urethral injury, such as during catheterization, and straddle injuries. And lastly, congenital urethral anomalies, which include posterior urethral valves, epispadias, and hypospadias. And then side note, gonococcal urethritis is a major cause of urethral strictures. Station 11, describe the image. What is your diagnosis? What are the possible clinical presentations of this pathology? So the image shows an intravenous pyelogram, which depicts a linear streaky appearance of ectatic or dilated contrast-filled collecting ducts in the medulla of both kidneys, otherwise known as a paintbrush appearance. So this is an intravenous pyelogram, and then it reveals a linear streaky appearance of ectatic or dilated contrast-filled collecting ducts. So the collecting ducts are right here, and then for them to be visible here, it means they're dilated. And then as you can see, all these structures are filled with contrast, and all this is happening in the medulla of both kidneys. As you can see, it's also happening this side. And this is what is known as a paintbrush appearance or a paintbrush sign. That is what I was describing here. So for the diagnosis of this is medullary sponge kidney. What are the possible clinical presentations of this pathology? So medullary sponge kidney can present asymptomatically, or it can present with recurrent UTIs, nephrolithiasis or kidney stones, hematuria, hypercalciuria, or flank pain. Station 13, describe the image. What is your diagnosis? What are the indications for this investigation? So the image shows an intravenous pyelogram, which depicts contrast within the right kidney's collecting system and no contrast in the left kidney's collecting system, representing a delayed nephrogram on the left side. So I'm sure you can see the contrast starting to collect in the right kidney's collecting system, but no contrast yet in the left kidney's collecting system. As you can see here, the contrast is still within the kidney on this side, but on this side, it's already out of the kidneys and it's already starting to collect. And then there is a radio-opaque spot in the left ureter with an absence of contrast distally, as well as mild dilation of the ureter proximally, indicative of a prevesical ureteric stone on the left. So this is what I'm talking about. There is a radio-opaque spot in the left ureter, which is right here, with an absence of contrast distally. So distal to this radio-opaque spot, there is an absence of contrast. I'm sure you can see the contrast here and the radio-opaque spot, but then distal to that, there is an absence of contrast, as well as mild dilatation of the ureter proximally, which is indicative of the prevesical ureteric stone on the left. And then there is mild hydronephrosis of the left kidney. So the left kidney is right here. I'm sure you can see that the renal pelvis is slightly larger compared to the one this side. So this is the mild hydronephrosis I was talking about on the left kidney. Number 2, what is your diagnosis? So this is obstructive uropathy secondary to urethral-lithiasis. And then what are the indications for this investigation? Remember, this is an intravenous pyelogram. So the indications for an IVP include unexplained gross hematuria, suspected obstructive uropathy, chronic or recurrent UTIs, evaluation of hydronephrosis, perioperative or post-traumatic urological evaluation, suspected renal masses or tumors, as well as evaluation of anatomy, which includes the size, shape, or position, as well as the physiology of the kidneys. So what I was saying is, whenever you have unexplained gross hematuria, you can order an intravenous pyelogram to rule out the structural causes of hematuria. Same case for suspected renal masses or tumors, as well as evaluation of the general anatomy, as well as the physiology, which is the filtration ability of the kidneys. So I'm sure you can see how this image is giving us an idea of how the contrast is being filtered, which in turn is giving us a general overview of how well the kidneys are working. So this picture right here is a delayed nephrogram on the left side because the contrast is not yet in the collecting system as it is on the right side, which is normal. So in this case, the delayed nephrogram on the left side was caused by an obstruction, which is right here. Lastly, station 14, describe the image. What is your diagnosis? What are the contraindications for a contrast-enhanced CT? So the image shows a non-contrast CT scan of the abdomen demonstrating a small hyperdense calculus in the right kidney. So this is a non-contrast CT of the abdomen because, as you can see, the large vessels are not opacified. And then this CT scan demonstrates a small hyperdense calculus in the right kidney. So this is the small hyperdense calculus we're talking about. And then the left kidney is clear. We can't see any of that on the left side. So what is the diagnosis? This is right nephrolithiasis or urolithiasis. And then number 3, what are the contraindications for a contrast-enhanced CT? History of anaphylaxis to iodinated contrast, acute kidney injury or severe chronic kidney disease. These are contraindications for contrast because remember, the contrast has to be filtered out by the kidneys. So if the kidneys are failing, definitely you're not supposed to give contrast.